I could tell the true story of why I got dressed up is because when we had the dress rehearsal and I came on, I think I frightened everybody because they had never seen me in my black hat.
Yeah,
So I think they were a little terrified. So I decided maybe I should look normal, um,
yeah,
and go from there. So I got dolled up for Cosmonet today.
We
good. Well,
appreciate it.
Antonio, I wanted to, sorry to stop sharing. I want to be able to see you guys while I'm talking. So can you help me with that? Just to make sure I've got this. Can you see me okay?
Yeah.
Yes.
Yep. Yep.
Okay.
Yeah,
So I'm sharing my screen, but for some reason I don't see you guys. Let me see.
Do you see everybody now?
I see you, but I see all 200 participants at the top too.
Are
So,
you okay?
All right, we can see your screen.
yeah. Okay.
Yep.
So let me, I don't know. Let me just start and we'll just start sharing. Okay. So Adamo and I were trying to figure out, what we wanted to talk about today. And an hour is so hard because there's so much we want to share in an hour. And I think it all starts off with having the right tools in your toolbox and just pearls that I think make a huge difference. Adamo, how about you? What do you think?
Yeah, I mean, listen, we would love to talk all day. We teach hands-on composite courses that are 2 days long, and something I know we felt that we could have used more time to really convey everything we want. It's such a complex topic, but I think what we tried to boil down is a couple of basics that are must-haves or an always for us, right? That we need to perform what we do every day. So hopefully, I mean, we hope everybody will enjoy it. There's obviously so much more to this, and this is just not even the tip of the iceberg. It's smaller than that, but for the next 45, 50 minutes, we're going to try and hopefully give everyone something to take home or try new on Monday.
Yes, for sure. So as you can imagine, Adamo and I lecture on different subjects of aesthetic dentistry, but when it comes to probably one of our favorites, it would have to be composite, because I feel, and I know Adamo feels the same, that no matter what type of practice you have, whether you're a solo practitioner, a group practitioner, an associate, I think it's a skill set that everybody needs to have. And you may not, be doing anterior composite artistry, but I think we all at some point in time are dealing with composites because it is so versatile, it is so conservative, it's easily repairable. There's just so many positive things and aspects of composite that it's my favorite thing that I do in my practice.
Yeah,
Adamo,
I
how
couldn't
about you?
agree. I couldn't agree more. I mean, I think it's in my opinion, if you can handle composite and make it rival porcelain, which we know is possible, you could do anything, right? I mean, I love the porcelain cases that I've done over my career, but yes, I have to be good at what I do to get that result. But let's talk about the other half that has to be good. You're ceramist, right? It's a duo team, which is amazing. Composite, it's one-on-one. It's you against you, and it's you against the tooth. So I think that's what makes those really rewarding for me. When I can match a single central in resin to a virgin tooth next door, I mean, that's pretty awesome. And I think that just shows again, it's you against you, and it really brings out the artist in you, which is it's amazing.
And one of the things that I hear all the time is people say, well, I like composite, but I can't charge enough for it, or it would make sense to do it. And I think, one of the things that we teach all the time is, what you charge is dependent on how much time you're going to spend on it, right? And that dictates what your fee is going to be. So if you can do these predictably and efficiently, so you're not spending 8 hours of the day working on a composite veneer, but you can do these fast, I would challenge anyone to say that composite is actually more return on investment than doing porcelain. And we make this example all the time in our course, and we talk about it, and when a patient walks into my practice, and if I'm going to build a smile in porcelain, the first thing I do is a records appointment, which is about 30 minutes to an hour. And I'm taking a set of photos, I'm scanning them. talking about the treatment plan, doing all the data collection that I need. And then when they leave, my work's not done. Now I sit down and I do the lab prescription for those photos, which takes me another 30 minutes or so. And I send it off to the lab. Then when it comes back, I get my digital design, and we use different labs, but whatever your cost is per unit for a wax up, an analog wax up or a digital wax up, you have that fee. So now you bring the patient back and you're going to prep the teeth, not prep the teeth, you're going to provisionalize, you're going to take a final impression, or you're going to scan. So the cost of that material, the cost of the time of that appointment, that's a pretty lengthy appointment in my office to do that. And then when they leave, they come back for a post-op again, and I do another records appointment. I take photos, scans, all that. And then when they leave, once again, I go through all those photos again. So when you think about what my cost per hour is as a doctor and how many hours it takes me to do a smile design case in porcelain versus somebody that comes in and I can do composite right on the spot. And oftentimes I'm not using a wax up, I'm doing free-handed composite. The return on investment's huge. So I love it.
I totally agree with you, man. I mean, and don't forget the 5 appointments in between the prep and the seat where they break things and they take up that chair time for the provisionals. But I had a great conversation one time. This is years ago when I first met Carlos de Carvalho. We sat with a couple of young dentists from NYU. He's one of my favorite people. And we were talking about composite versus porcelain. And the younger dentist said, well, we're in New York City, we're going to do porcelain because, I mean, rent is $8,000 a square foot and so on and so forth. Mm-hmm. And Carlos, they asked him, what do you charge for porcelain versus composite? And he says, there's no difference. And I took a step back and I was like, wait a minute.
Yeah.
I go, can you explain? He said, yeah. You're not paying me per my material. You're paying me as a clinician to make the best decision for your tooth, aesthetically and functionally. So whatever material I pick, you pay the same price. A veneer costs the same in porcelain. And I thought that's genius. Obviously, we're dictated by insurance a little bit, so it's a little tougher. But I will say this, as time went on and I got better with my composite, I'm sure you'll say the same. My composite fees are not cheap. And I would bet they rival some crown fees in my local area as well. So you can get the return on investment for sure. And again, I just love the fact that it's me against me and let's do it and go.
Yes, for sure. So before we get into the tips and tricks, I think it's really important, no matter what you do in your practice, that if you're practicing cosmetic dentistry, that we're doing it right, the right way. And so Adamo and I truly believe in doing the correct bonding protocol and isolation to get predictable results. And that's just something that you have to do to make this work. So this is a beautiful case by Adamo. Why don't you tell everybody, kind of walk them through? I guess this is like a typical patient that might walk into your office that has some bonding on their front teeth and they say, Dr. Adamo, I want these fixed. I want 2 porcelain veneers. Why don't you pretend, I'm your patient? What are you going to say to me?
What am I going to say to you? So I am going to ask you, why do you want 2 porcelain veneers? And I'm going to guess your answer is going to be because the composites there don't match, right? This patient was a little different than that, but she wanted composite, but most people don't. They come in for porcelain. I have one case I show on a single veneer that it had a tiny class 4 on the incisal edge, and the patient wanted 12 veneers because she said no one could match the one front tooth. But in this case, I'm sure you would tell me because they don't match, and I would say, well, I am accepting your challenge. Give me a shot to do them in composite. It's more conservative. I'm not saying it's going to be cheaper because now that I know you want porcelain, I'll probably charge you. And we can match the same thing in resin, destroy less tooth structure, and so on and so forth. And, we talk about the title of the lecture, which is Tips and Toolbox. And I will say the first thing in my toolbox that you're going to see is a rubber dam. Okay. And this is not split dam. This is individual tooth. And we're going to get to a slide because I know everybody sends me messages about every reason not to do it this way. I know there's not a whole boatload of science about it, but common sense tells me that I'm isolating and I'm going to bond way better with this rubber dam on the way it is than I would if I didn't use it. So number one tip in my toolbox, 100% is a rubber dam. I use it for everything, preps, inserts. There's plenty of studies that show that it's effective. And even if there aren't, I mean, common sense just tells you there is no liquid there. There's no heme. There's no nothing from underneath there. So why wouldn't you do that? It's stress-free dentistry for me. So I prefer to do it that way.
I think most people wouldn't argue that you're going to get the best bond under rubber dam. I think a lot of people get away from it because they're unfamiliar outside of dental school,
Sure.
right? And the way dental school teaches you is, I mean, I hate to say this, maybe not all dental schools, but at least in my experience, I mean, it was pretty basic. It wasn't to the level that I'm doing it now. And it takes a little bit of practice, but out of all the procedures that we learn in dentistry, I mean, you learn about occlusion, about doing full mouth rehabs, veneer preps, provisualization, implants. Rubber dam is probably the easiest thing to learn. And I mean, in our course, when our participants come in and do the rubber dam course, they come back Monday morning and they're shooting us pictures of all their isolation on all.
Yeah.
I mean, it's not hard. You just got to learn it. That's all. So tell us about this case, Adamo.
So yeah, so actually this patient sent me an email after about 60 referrals, including Pascal Magnier. So I was pretty nervous when she came in because she's a New York City attorney. She had a really bad experience to damage to the papilla between 8 and 9 from old composites. She finally got the papilla healthy and came to me with the resin. You saw she didn't like them because they were wider and they didn't blend in with the teeth. I mean, she questioned my bonding protocol. She knew about biomimetic dentistry. She knew about rubber dam isolation. So I talked her through. And
let's stop for a second. When a patient knows about biomimetic dentistry, you think twice before treating them.
Yeah, I was contemplating referral to a couple of my friends down the road or in Long Island, but she was super nice, super sweet. I think that's a good point, Amanda, because a patient like this could scare you, right? A New York City attorney who flew to meet Pascal Magnier to discuss this and then ended up in my chair through referral. So most people would say, But
do you have the email that she sent you, by the way? You guys have to see this. It's not a presentation, right?
But oh
my God, it's the best.
But with the protocol, I was confident I could do it, right? Because I'm going to be protective of what her concerns are. Her gingiva. Obviously, with this rubber dam isolation, we're fine. The biggest thing I get with isolation like this is I can't fit the matrix. Well, here's proof in the pudding that you can fit your lingual matrix, even with absolute isolation. You just have to trim it a little bit. So I test it first to make sure all the old resin's removed. We're going to place our bevel, sandblast, so on and so forth. And then for me, I always treat the smaller filling first. Right.
So did you just use her existing tooth shape, Adamo? Because it looked pretty good, right?
I love the existing tooth shape. It was more the colors, right? There wasn't translucency. Those effects weren't there. So I made a lingual matrix. She had no occlusal issues. She had no chips, no problem. So I just made the putty matrix off her existing teeth.
Yeah. Okay.
Right. So try it in. And again, I isolate and restore the smaller restoration first to get that shape perfect. And then it gives me more room to play on the bigger one. So here you can see the Teflon tape on the adjacent tooth. I'm going to work on 8, build that up to contour.
And you made a really good point, what he just said. You're doing 2 restorations next to each other. Always do the smaller restoration first. Why is that? Because if you look at tooth number 8, it's almost a full contour. It's not that difficult to be able to add a little bit of mesial composite to figure out what the correct anatomy of that tooth is. Well, whereas if you started with number 9, that is more broken, you're really going to have to rebuild that tooth and hopefully that you nail that anatomy the first time. So pick the smaller tooth first to build and then do the bigger one. And another thing I want to say, because this is another important thing. So that's Teflon tape or plumber's tape or whatever you want to call it. And there is a difference between the Teflon tape that you get at the Home Depot or Lowe's and what we call Tape Tricks, which is a dental Teflon tape. Tape Tricks is much thicker. And when you etch and bond, it really won't eat through the Tape Tricks. Whereas the Teflon tape, the plumber's tape, which is right here, you have to be careful because if you etch or you bond and you scrub, it can eat through and you'll end up bonding it. So there's indications for both. One's not better than the other because sometimes tape tricks is too thick. And I feel like if I bond to it, I'm losing a little bit of contact. So that's when I would prefer the plumber's tape. Yeah,
so I would apply the bonding agent, then put my Teflon tape and then cure. So you can see this tooth is built to full contour, a little short of final polish, but my shape is there. I'm happy with it. So now I have plenty of room on the other tooth to match. So I'm going to do the same thing, Teflon tape on the tooth that I finished, etch, bond, whatever protocol you do is fine. Lingual shelf. Then I'm going to put my Denton color in there. I'll add my trans where I need. I'll go to full contour, and then we'll go from there. And one other tool that's in the toolbox is a pencil. I love to draw on teeth because I completely think, and I know you agree with me, that cosmetic dentistry is a complete illusion. So if you don't nail your line angles in position shape, you're going to mess up your tooth sizes. So, I mean, I'll draw 3-4 times and start to shape with my discs, which I do most of this with the Cosmetic discs at this point. And then I'll get it to full contour, take it off and go to polish there. And there's the final result. And you know, listen, whoever did the composites initially, which I don't know, they know how to handle composite. I mean, the shape is beautiful, right? Their line angles are great. It's the color that's missing, right? So we're going to talk about color now and how important it is to map that before I do anything. Before I put the dam on, we'll explain why in a minute. But I already know what composites are out. Amanda's going to show you a tip I learned from her on how to have your composites ready and your shade mapping done before you even start working on the teeth. So my patient was super happy for a lot of reasons. I mean, the aesthetics came out great. It's a case I'm real proud of. She was super happy that I did not touch her papilla between 8 and 9, because if I showed you the photos that she had sent me, she got a pretty rough job done on there. And she was that was the main thing she was impressed with, is I can't believe that the rubber dam was so good and you didn't hurt my papilla and I feel great. And so on and so forth. I was like, well, what about the color? That's pretty good too, don't you think?
That's beautiful. It's beautiful. I love the interproximal translucency on the lobes. Really pretty. So, you know, we always start off, I think one of the most difficult things, there's two things that are the hardest things about composite artistry. One is the color, understanding the color. And the second is understanding anatomy, because for some of us, the last time that we really spent time focusing on dental anatomy was when we had to do wax ups in dental school. And some of us still do wax ups in our office. I do not. So I do everything in composite. So when I build a smile design or anything, I mock it up in composite. So that's my dental anatomy that I do. But unless you've really honed those skills outside of when you graduated dental school, dental anatomy is huge. And that could be a whole separate lecture to just talk about understanding the nuances of dental anatomy. But we wanted to focus in today on color, because you got to be able to understand what you're looking at. And I think that's the hardest part, is we have all these definitions, right? Because when you look in the dictionary at the definition of color, you see some words that actually we might have remembered from dental school, such as hue, value, and chroma. But what does all of that really mean? And I have taken courses from the greats of composite artistry, and probably the easiest, the best explanation of color was from my friend Bob Margis, and I still use it to this day. So Bob, if you're out there, thank you. But he says it like this: if I were to give you a bunch of glasses of water, all with the same amount of water, right? And then in the first glass, sorry, my computer's lagging a little bit, and I give you a bottle of red food dye. Well, that red food dye is your hue. And then in the first glass, you're going to put 1 drop, in the second 2, and so on and so forth. So if you look at the color throughout all the glasses, the hue is the same. It's red, right? What's the difference? The difference is the saturation, which is what we call chroma in dentistry. So in dentistry, the hue would be, is it A, B, C, or D? The chroma, or how saturated it is, would be, is it A1, A2, A3, A4? But really the most critical factor in choosing color is not hue or chroma, it's the value, which is a measure of how light or dark something is. And it's usually where people go wrong in choosing value. So I'm going to hope to demystify for you your understanding of how to pick the right value for your composites. So a tip right here, I mean, no matter what shade guide you're using, I think most people probably use the Vita Classic Shade Guide. Rearrange it according to value, because when you buy it from your manufacturer, it comes in, you know, the hues and the chromas, but it's not according to value. So you can Google it and find out how to set it up according to value. If you notice, I also cut off the little necks of the teeth there, and I make a little ledge that just helps me put it flush to the tooth for shade tab photos, so that when I take the photo, my shade tab's not sitting in front of the tooth or behind the tooth, but actually in the same exact plane, which is critical.
Yeah, that's a great point, Amanda.
Yeah,
With the
because
shade
I mean,
tabs.
you know, it could be the right shade, but when you have it too far forward, just a hair, it looks light. And if you have it behind the tooth, it looks dark, right? So another tip is cross polarization. And this is something that Adamo does a big lecture on this with ELAB technique and everything else. But what it does, it's just a little filter that you put on your flash, whether it's ring flash or twin flash, and it removes all the specular reflection so that you can really evaluate the nuances and the color of the teeth. So this is Adamo's photo here, but you know, and I always explain this, and when people see this photo, they're like, well, why did you take a photo with 4 shade tabs? Why not 1? And the best analogy I can give you, this is my female analogy, maybe men can understand too, but if I have a black t-shirt and I'm trying to match my black t-shirt to a pair of black pants, right? So if someone just handed me one black t-shirt and said, does this match your black pants? I can look at it and say, it's a little too red of a black, it doesn't match. So then I give it back to them and they give me another black t-shirt. And I look at that one and I say, well, this one's a little too gray. And we can do this all day long. And I can say, this one is closer, this one is not, but I don't really know. But if they gave me 4 black t-shirts that I could lay next to my pair of black pants, then I can really have some relative value to be able to say which one is closer, which one is not. So it's the same thing when it comes to taking 50 shades of white, right? I mean, you can go all day and hold 1 tab and do a shade guide, but when you hold 4 and you take photos and you move it along like that, you really have a better sense of what tooth has a better value to match. Mm-hmm. And Adamo, I know you have a ton to say about this with your ELAB, and but anything else that you want to add about that?
Yeah, I mean, for composite, the great thing is you're seeing the color there and you can match it. When you're dealing with a lab, I can give a whole lecture on that lab communication, which we don't have time for. But as far as your cross polarization photo is, when I'm doing an anterior composite, I snap the photo cross polarized immediately and I'll print it and I'll leave it right on the counter behind me, because I can see where I need to add trans and where my halo is and if there's any different effects. Without that, especially with rubber dam on immediate dehydration, it's almost impossible. On Teflon tape over the other tooth, you can't see the shade map. So take a photo, take 2 seconds to print it, and map out your color scheme to go forward. That's something that works really well for me.
Yeah, agreed. Another little trick, you know, if you're trying to replicate another tooth that has just a lot of characterization in it, and you're trying to see, well, how deep is this color? Is it more superficial? Is it deeper in the layer? And where do I want to put these layers or tints? It helps me sometimes to just do a little post-processing. So if I take the photo, and you can shoot tethered or however you, or download it, whatever you want to do. But if you increase the contrast and the saturation, it helps you see those areas more. So when I do that, you can kind of see the interproximal lobes, how far that translucency extends is more visible than when I didn't increase the saturation and the contrast. But this is the key right here. And this is the concept that if you get this, it will save you so much time with shade taking and figuring out what color, what value is correct. So when we break it down with enamel, there's really 2 types of enamel shades. There's enamel with chroma, or we call chromatic enamel, or there's enamel with less chroma, or achromatic enamel. Okay, so chromatic enamel are typically the ones that have the simple names like A1 enamel, B1 enamel, straightforward. those chromatic enamels tend to keep the value the same or raise it just a bit. Okay. So those are some custom shade tabs, and you can see the chromatic enamel right there in those shade tabs. Now, enamel with less chroma, or achromatic enamel, we call it, are enamels that have the more ambiguous names like iridescent blue, incisal light, milky white, and those tend to lower the value of the tooth. So the problem that I see often is that people think when they build a tooth in composite, they think, okay, I laid my dentin shade, and in nature, dentin is the underlying structure and enamel's the top layer, and enamel tends to be translucent. So I'm going to put a really translucent enamel on top of my dentin. So they choose an achromatic enamel that they lay over the whole surface of the tooth. Well, what ends up happening is the tooth grays out. It becomes a completely achromatic tooth, kind of gray. And the area that we usually see achromatic enamel is really in the incisal third, where you have the translucency, or the interproximal lobes, as Adamo showed us so beautifully in the last case, right? And then we have dentin. Dentin's pretty easy. I mean, those are usually called A1 dentin or A2 dentin. There's also body shades. And what are body shades? Body shades are really like a universal. It's a blend of dentin and a chromatic enamel. Okay, so look at that dentin shade tab over there. If that were my dentin layer and I laid that achromatic enamel over top of it, you can see how gray that tooth would be, right? Whereas if I laid the chromatic enamel on top, it would be the same. Maybe we can raise it just a bit. So really look at your color. You know, don't memorize some formula, but look at the color and say, is that enamel chromatic or is that enamel achromatic? And then look at your tooth and decide, where are you seeing the enamel color? Is it, where's the chromatic area and where's the achromatic area? So did I cover everything, Adamo? You've heard me do this 1,000 times. Is there
Yeah.
something where I make sure it's hard to cram everything in an hour? So
No, I hear you. I think, yeah, I think that's probably the most critical point. I remember in our lecture, in our course in December, there was a clinician there who is an outstanding clinician. We spent a lot of time on this exercise and going over chromatic, and he came up to us and said, I have to tell you, for the life of me, I didn't realize the difference in the effects of achromatic versus chromatic. And I see it all the time where people message me, I know this shade is A1, but when I put my final layer on, why does it look so much grayer than the other two? And I say, well, what did you use? I used milky white. And I say, why? And they say, well, because I need an enamel. I'm like, wait a minute. You have to understand, what is that composite going to do? Is it going to lower value? I mean, and all achromatics are not created equal, as we're going to see shortly, right? So we'll get to a little further that in that case example that we have. But I think that's key. Color of your composite. And then the other part we're going to talk about now, color of your tooth. So one tip that I always like to give people when working on any kind of anterior restoration, even composite, is beware of dehydration, right? Because teeth dehydrate quick. And if you go forward, Amanda.
Yeah, and guys, I just love this. This is just shows, Adamo and I just joke, like, I'm not a half-asser, but Adamo is certainly not a half-asser. He does everything to the extreme. And so when we talked about dehydration in our lecture and how we can show participants this, he literally went home and did this. So you're going to have to check this out. It's awesome.
Yeah, so if you look at this next slide, here's a tooth. This is a photo from Style Italiano of a hydrated tooth versus a dehydrated. You can see clearly the difference. And there's a great study by Berkey that showed that teeth didn't rehydrate or return to baseline within 30 minutes. So Amanda's right. I like to do everything hands-on and really go for it. So I took my assistant Stacy, as you're going to see in the next slide. And if you look at her photo, she's about a B1, according to that shade tab. I put a rubber dam on her. No, she wasn't happy. She did not like me for a little while. I let her walk around the office like this for 30 minutes. And then I removed the rubber dam. And I want you to look, you can see the clear delineation of dehydration immediately following removal. I mean, that's instant zoom right there. We didn't even have to bleach her. And then 30 minutes later, Not even
Mhm.
close. I still can see it. And an hour later, I still can see where the dehydration point was. So if you guys
Mhm.
start rubber damming and then go, oh, I got to pick the shade of my teeth, you're done. I'm
Yeah.
working on a study. Actually, Devin and I, my resident, are done. We're just about done with the write up, and we did objective analysis via eLab of dehydration on 5 subjects over 24 hours. And as you'll see in the conclusions and the tips for dehydration in the next slide, in my opinion, you need to take the shade within the first 3 minutes. And if you don't,
Yeah.
your color's off. And
Yeah.
some of the subjects that I studied with Devin, it took up to 24 hours. Some didn't even completely rehydrate in 24 hours. So if
Mhm.
you don't get the shade right on a single anterior tooth within the first 3 minutes, you're best off waiting 48 hours to bring the patient back to retake the shade photos, because you're just not going to get it right.
Yeah. So can you tell everybody just like real quickly, I know we don't have a ton of time, but just the flow in your practice from the time the patient sits down and the shade taking and the photos and all of that.
Yeah. So when I walk into the room, as opposed to like my partner Larissa is super bubbly and chats with the patient and so on, I get down to business. She laughs because I don't say a word. But when it comes to, if I'm doing a big, especially let's just say a single tooth, I walk in, I say hello. I'm not going to talk to you right now. I need to pick the color of your tooth. Give me 3 minutes and then I'll say hello again. And literally, Devin's there with retractors or Melanie, and I'm taking all of my photos, picking all my shades. If it's composite, I'm mapping it out now. Then I'll either send Devin or Melanie to go print my polarized photo if it's a composite, and then I'll have my conversation with the patient. Because if I
Mhm.
lose that initial 3 minute, I'm done.
That's
And I
right.
know, once the rubber dam's on, the dehydration, it's like you just saw it, right? So
Right.
I literally have, before the patient in the room, I have 3 cameras in there, polarized one, my artistic one, whatever I want, my shade tabs are ready, retractors, and I do this immediately, barely saying hello to the patient. And then
Yeah.
once we're starting to get everything lined up, then I'll have a little conversation.
Yeah, and a little business pearl for you guys too. So like Adam said, like take the shade right away. But if you can always tell patients what to expect before it happens, then they think you're genius. If you tell them after the fact, then they think you did something wrong. So what do I mean by that? If you come in, I tell them, listen, I need to take the shade right away because your tooth will dehydrate as we start to work because I'm going to isolate it and everything else. So when you walk out of here, the color of your composite is not going to look right. It'll probably look too dark on your tooth. I go, but as your teeth rehydrate, I go, the color will balance out. And that's why we do this at the beginning of the appointment. So if you tell them that, it's a 30-second spiel. When they walk out and they see that it's off, they're like, oh, you told me that, instead of showing them the mirror, because that's the first thing they're going to do. And they'll be like, well, this doesn't look so good, so always tell them ahead of time what to expect. So what do you do? Because I don't know what composite shades you have. I don't know what systems you have. And you don't have to have a custom shade tab. I would recommend it. But say you don't have one. Everybody has a glass slab of some sort. I recommend a large one. But what you would do is roll out your composite into a small kind of patty. Make sure they're all the same width or thickness. And cure it, because when you cure the achromatic enamel, you can see how different they are. So already look at how different all of those shades are. So if I layered the tooth with one of those versus the other, it can be a little too cool. It can be a little too warm. And then the same with tints, a little goes a long way. But Adamo and I love a big glass slab, about 4x6. And what we do is when we pick our shade at the very beginning and we mock it up, we take our gloves off, we put new gloves on, and then I write down the shades I'm going to use. I put my glass slab on top and I pre-roll my composite into the shape of how I'm going to apply it. And I put an orange cover over it. And the reason that's important is because the moment that these hands go in the mouth, I want them to touch nothing. I don't want to manipulate the composite in the mouth over excessively, because every time you have to manipulate the composite more in the mouth, you're going to introduce porosities or bubbles or voids. So if I've already pre-rolled everything, the shade, I'm just picking it up and placing it, picking it up and placing it. And we're going to show you a few more slides with that, but that technique for us has been really predictable. But this is Adamo's case, and I think it really proves the point of understanding what you're looking at with chromatic enamel and achromatic enamel. So Adamo, take it away.
Yeah, so, again, shade mapping is everything. If I look at that adjacent teeth, and when we teach composite, we don't just teach one class 4 method, we teach 4 because I think there's a different way to do every single tooth. In this case, I'm looking at tooth number 9, and without too much time, I mean, I see a lot of color real deep in that tooth. I see violets, I see grays, I see like an orangish something, some white. So my first thought is I'm going to need some tint in this case. So what I did was I actually built this case up monochromatic. And then a technique Amanda and I teach, very similar to a lab tech pressing an ingot in one color and cutting back a window and adding, is the same thing. So I cut back this window, and you can see I laid very, very heavy tint as far lingual as I can. So now I'm going to cover that with a little bit of chromatic enamel, because if I do all achromatic, you're going to see that tint from a mile away. So I want to dummy it down a hair, and then I put a very thin layer of achromatic over it so I can see my effects. And you can see that here. So this is a combination. And again, you just need to understand your color, but which achromatic did I pick? And again, this is why you need to know your system. And is your achromatic cool? Is it warm? Is it neutral? But if we slide along that matrix there, that's pretty much the color that I laid over that incisal edge. So I needed to dull down the tint, but I also want to put achromatic only in that incisal third to bring out the effects that I put. If I drag this too far up, that's when the tooth starts to gray out and you start to see too much of a difference from one restoration to the next.
Right. And when you look at this case, there's so many ways to build this tooth. Now that you saw that patient had an existing composite. So by the time Adamo took that composite off, he was way lingual. So he had that opportunity to lay that tint really intense and deep, right? Because he knew he could mute it out with layers on top. But say you have a tooth that's not fractured and you wanted to use tints, well, then your tints are more superficial. If they're more superficial, you want to be really light with them. So there's just so many ways to do it. And if you look at that interproximal lobe that kind of has a gray blue translucency, he did it with tint. That was layered deep. Now look at the achromatic enamel that's next to the one that's circled. That one is kind of like a clear blue. If you're a layering person, if you don't like tint, then maybe you can use a little of that achromatic and roll it into a lobe for the interproximal lobe. But no matter what technique you use to build the tooth, it's understanding what you're using. So, a lot of people do the multi-layer technique when you start with a lingual shelf. Looking at this, hopefully you guys can tell it's an achromatic enamel. If it were chromatic, you would see a little bit more, even though it's real thin. So let's pretend we'll just look at a couple cases, and I'm just going to talk. It's so weird to do a webinar and not be able to ask questions, because we ask participants this question. So this patient comes in, she just wants a diastema closure, and I'm using one shade. So if you had to guess what shade, I used an achromatic enamel. You can kind of see the translucency in the lobes, right? But it's choosing the right achromatic. And then this patient chipped a tooth, and you can build this a couple ways, but because it's just a little amount of tooth, what I did here is what we call our window technique. I did one full layer in like a dentin shade. I cut it back and I did a little tint, and then I put some achromatic enamel on top. So hopefully you can see some of that color that's built into that, and you can see that achromatic on top that preserves that translucency. Because if I put chromatic enamel on top that's too thick, it would hide the color variation that I built in there. It would hide a lot of the tints, right? So that's where achromatics are nice. But thicker the achromatic is too, the more it will hide it. So it's a combination of depth and layering to understand the effect of color. So when it comes to armamentarium, we keep it really simple. And I'm not just saying this because we're doing a Cosmedent webinar. These are some of the instruments that I have. You can see not all of them are Cosmedent, but a lot of them are. And I'm going to show you what we use and why we like it. Number one is the Cosmedent IPCL and their sable brushes, number 1 and number 3. So, some other armamentarium too. The glass slab, we already told you, a 4x6, something we can roll our composite out on. We need Teflon tape, whether or not you want tape tricks or just plumber's tape is fine. some kind of wetting resin to either dip your brush or your instrument so that the composite doesn't stick to it, and a little goes a long way. And so Composite has some, other companies make them as well. The key is there's no HEMA, because if there's HEMA, you can get some water absorption, which can cause some discoloration of your composite. So take home message, don't dip your brush, your instrument in bonding agent, because most bonding agents have HEMA in it. So the cut and roll technique, whether you use compules or you use syringes, if you're using syringes and you're using your glass slab, make sure you're not cutting it right at the tip of the plastic syringe, because you can introduce little black flecks into your composite. Okay, if you're using the compule, roll it out. But when I roll it out, I'm doing a couple of things. I'm getting any air bubbles out, and I'm also shaping it and softening it into, like I said, the shape of how I'm going to apply it. And this is what I mean. So here's an achromatic enamel. You can see by how translucent it is. And I know that I want to put it along the incisal third edge. And because I'm going to lay it out in that shape, I pre-roll it into kind of that sausage shape so that I can pick it up with my IPCL and lay it down, and there's barely any manipulation in the mouth. It almost, within a few seconds, I can lay it flat and it's done. Whereas if you take a big chunk, stick it in the mouth and start cutting away, you're going to introduce the likelihood of getting more porosities and voids. And so this video just kind of shows you, I've already done my mock-up, I've written down the colors that I'm going to use, and then I put my glass slab on top. And now I'm going to roll my composite, right? So you can see the different shades, and this is all with clean gloves, probably a little more for Denton, right? And then you can see as I get to the achromatic shades, the shape of it starts to change a little bit, because depending on where I'm using it on the tooth and how I'm going to apply it, I want it ready to go. And once that's done, I put an orange cover over it, keeps it dust-free, protects it from light, and we're good. And the same holds true with tints. I also put it on there and label it. But what's nice about the IPCL is that it's super skinny and it's flexible. So that I love. And this is kind of an example of how I use it here. Because it's so skinny, it's great for doing the little Denton diffusionary lines that you do in Denton. And that's the sable brush. You can see that's the number 3 sable brush. You can use it on the broad flat side like this to smooth down any margins. But then you can turn it on the side where it's skinny to kind of define that Denton diffusionary line just a bit too. So the two together for me are wonderful. And yeah, I already showed that video. Good. So then when it comes to tints, the same thing. You want to, if you're mixing your tints, I go ahead and mix it ahead of time. I don't want to have to play with anything once I decide to go into the mouth. So if you mix your brown and your white, label it, have it ready to go so that you can start building your tooth. But I'd recommend doing it with the number 1 sable brush, which is really small. And then after you dip it in, kind of wipe it clean just a bit so you don't have too much tint. And then the finishing products. Adama, you want to talk about some of these that we always use in our courses too?
Yeah, I mean, for me, there's nothing better on the market. And again, I don't use 100% exclusive Composite stuff. I'm not saying that because we're on a Composite webinar, but all of my shaping, I mean, I do a lot of, like you said, the way we roll out the composite, there's not a ton to be done, but between the blue and the white disc, I mean, that's 90% of what I use for anterior composites. And in my opinion, in terms of polishing paste, nothing beats enamelized. I mean, the luster that you get is just, it's beautiful. Do I use it all the time? No, because not every tooth needs to be that shiny, right? It's all dependent. But I follow the flexi disc sequence, and then if I need extra, the enamelized comes out. But they're just, you know, with the size difference. I mean, I even use the flexi disc, the blue one, because it bends a little. It's not as stiff. I'll round off and finish my veneer preps with it. I use it everywhere. So it's a really versatile system that I enjoy.
Yeah. And, you know, we recommend that you spend 90% of your time in the coarse disc, getting the shape right, getting all irregularities out, because if you have any bubbles and you think, oh, well, I'll just go to the next grit, that bubble's only going to get worse. It's not going to get better. So get rid of it with the coarse disc before you move on to the next. But where I think Composite is a lot different than other disc systems out there is the blue disc.
Yeah, for
And
sure.
the blue disc for me, I think what's unique is that it flexes without cutting so aggressively. So what's really nice is after I get the general shape, if you want to create those really cool incisal edges that have little irregular stuff, turn the blue disc on its side like you see in that photo, and it just will lightly notch it without like all of a sudden you take out a chunk of your tooth, you know? So it's really nice. And then when we teach secondary and tertiary anatomy, you can see how rough that anatomy is right now that I create. What we do is we create it and it's rough because it's easy to create it rough with a burr, but then you soften it or you mute it out with the blue cup. And the blue cup is really nice. We kind of run over it and it gives you the perfect amount of texture and depression without looking so manufactured.
Yeah, I think for
So
me, Amanda, one of the coolest things about the blue disc, or one of the things that saves me, and I see a lot with a lot of people I mentor, right? Where they're doing 6 direct composite veneers, and you look at it from the incisal edge, and I use the white disc in between the line angles, but outside
yes.
the line angles, I have big Italian hands and they're a little heavy. So if I use a white disc, I devour that roundness, all right? I don't get a good facial emergence. So, but with the blue disc, because it flexes a little, I can reshape without worrying about devouring that. And I see it time and time again. I look at an incisal view of somebody's composite veneers and it looks like a triangle because the white disc is just too aggressive. So for me, once I go in between the line angles with white and then outside the line angles, I use a blue disc because I don't want to, like the beautiful shape you created here. If I would have done that with a white disc, that's gone. It moves the line angles in, it changes the whole shape. So I love the blue disc for that reason.
Yeah. Well, I know we want to get to questions, so I'm going to go through and let you talk about this section here, Adamo, and then we can answer some questions.
Yeah, so very quickly, the other thing in my armamentarium is magnification. And, I started, I think, with 2 loops and then 4, and now I have 8 loops. And Carlos de Cavallo convinced me to well, he didn't have to convince me. I just saw his work and I bought myself a microscope. And working under a microscope has completely changed what I can do, because not because I'm technically a better dentist, it's because I can see it. And this is a great quote from my mentor, Gary Alex. I do not believe it is possible to do excellent dentistry without magnification. I think it is very difficult to do even good dentistry without magnification. And I'm going to show you this last case, it's a full facial veneer. You could see I'm just about to put the final layer on. But if you look at this, all the little details in texture that I put on the, can you go back to that picture, Amanda?
Yeah, sorry. Let me get back. Yep.
All the little detail I put in number 8 on the facial, the little pericomata, the indents, and so on and so forth. I did that at 20 times magnification. There's no way that I'm going to see that detail with 4 times loops or 2 times loops. It's impossible. So if I can't see it, I can't do it. I know one of my very dear friends is on this webinar listening to us, and he is one of the best anterior composite dentists on the planet, I think, Art Volker. He's amazing. And Art,
so good and so sweet,
works under a microscope. And yes, it takes time and practice to understand color and layer the way he does. But the detail that he puts in is not only because he's good and he practiced so much to get there, but when you can see something that big, you're giving yourself a much better shot. So I don't do anything anterior anymore without a microscope, because I can't put the texture that I just did on this tooth number 8 and replicate 9 if I can't see it.
Right.
So I think magnification, whether it's minimum 6, in my opinion, to 8, but if you can get yourself a scope. I used to do the binocular scope. I didn't love that for anything but anteriors because it's hard to manipulate, but I just upgraded to the 3D scope from Siler you're going to see here in the next video, but you'll see the tooth that I'm preparing. It's about 20 mag.
So hopefully, it's a lot to cram in 1 hour. We want to take questions, but we've given you guys some tips and tricks and what to have in your toolbox to at least understand color better and to have the armamentarium to get, the results that you want.
Guys, I had the honor to watch and film this live for Amanda, and you'll see by the end result, the work is just, it's world class. It's beautiful. It was amazing to see, and I'm so fortunate that I got the video and learned some tricks myself. This was awesome.
This was before our first course. Adamo came down and it was like the first take, Adamo, right? I'm like, well, why don't I build a tooth and you just video and you tell me, let's see how this goes.
I would say it turned out pretty good.
So anyways, thank you guys so much. We have, less than 10 minutes. So I want to make sure that we get to some questions. So I'm going to stop sharing my screen and hopefully, all right. So
Hi, thanks so much.
I see you guys again.
Wonderful program. Yeah, we've got a lot of questions. So you two let me know when to stop asking them because I could go on for quite some time. So I'll start in the order we received the questions. What type of camera lens flash does Dr. Notarantonio recommend? Your photos are gorgeous.
Okay, so my answer to this question is it's not the Arrow, it's the Archer. My first suggestion is take a good photography course. There's plenty out there. Amanda and I do one. There's Miguel Ortiz. There's When the Pictures Really Matter. There's so many out there. You need to understand the camera, the flash, and the light. I have to the left of me 5 different cameras for 5 different purposes. So I can't really give you one. It's a macro lens camera for sure, but I would recommend getting yourself into a course because once you understand the basics and a little bit about light, photos are super easy. And thank you for the compliment. I appreciate it.
Thanks for answering that. When finishing composite restorations in the anterior, which position do you sit when finishing? Do you check from the front? Do you have the patient sit up? Do you take them outside? Natural light? I'm sure both of you do it maybe differently.
So depending on what they mean by that, to evaluate primary contour, I have them sit up straight and I take a picture because there's no eye dominance. You take a picture, you can really look at it to see if it's canted or straight or equal, and that's primary contour. But as far as shade, that's done at the very beginning before they're dehydrated. And again, we take a photo, sometimes a polarized photo, to be able to see the value right away. I typically with a camera can do that and not need to make them stand by a window to look at the shade at the very beginning. But finishing, the words finishing to me usually just means like polish, tertiary anatomy, that kind of thing. Primary contour is done with the disc, the coarse disc, and shade is done at the very beginning. So.
Thank you. And what are your favorite clamps for rubber dam, and which rubber dam do you prefer? And this is, I think this question was for Adamo, but.
Well, we do the same. So Adamo.
Yeah, again, either one, we teach it the same and we do it the same. And what we teach is what we do day to day. So that's good. I mean, clamp selection, as far as your primary clamp, you just want to make sure that at least three of the 4 tips of the clamp engage the tooth so it doesn't rock. So again, that's all depends on the tooth that you're using as your anchor. But my favorite clamp for a secondary clamp for retraction is the B4 by Brinkner. It's awesome. It's small. It really does a nice job of pushing the tissue down. And I use that religiously when I'm cementing stuff, or if I have to get a little more retraction. As far as rubber dam goes, for me, there's only one answer. It's heavy gauge and it's latex. And I think Nictone makes the best rubber dam on the planet.
Yeah, it practically inverts itself if you get the heavy gauge. And when he said the B4, it's really important because if you haven't done a lot of rubber dam, B4 is amazing, but it's not your anchor clamp. So you're not going to be able to hold down the rubber dam with just a B4.
Oh, no.
Like you need other stuff. So, That's another lecture.
Okay, thank you. And what cases would you do free-handed versus from a wax up versus injectable technique?
Mhm. Well, for me, if I'm changing occlusion, I'm for sure probably going to get a wax up and do injection mold technique. And I can always cut back and layer and change the facial. If I'm just adding facially or a little to the incisal edge, I like to freehand. So, I think that's a personal choice. It depends on how comfortable you are with anatomy and doing it. But I can tell you, the more you practice, the easier it gets. When I first started doing composite artistry, I relied a lot more on the designs from my lab. But as I started to do more, I got really comfortable, and so I'm freehanding composite a lot more. But that being said, if I'm changing occlusion or anything, it takes a lot of time to manage that with composite. I'll go ahead and send that off.
Thank you. And what material do you use for micro etching?
For micro etching, I have a Prep Start by Danville in every single room. I think it's 50 micron aluminum oxide. But yeah, I cannot practice with that. That's another tool that we didn't have time to add, but we literally have one in every single operatory.
Same. Yeah, when you see it too under magnification, how different the surface of the tooth structure looks after you micro etch it, you'll realize that the bond is way superior if you can do it.
Thanks. This is another rubber dam question. What is your trick for placement of a rubber dam to get the entire papilla under the dam, not just towards one contact?
That has a lot to do with hole size.
Yes.
So yeah, if you don't do hole size and placement. So if you're using one of those preformed templates, not that they're bad, but sometimes position of teeth are crowded, overlapped, or they're spaced. That hole size in between is not the same. So if you have too much dam between the tooth, it's either going to bunch up, or if you have too little dam between the tooth, or your holes are too big, then it's only going to cover part of the papilla, and then you have like papilla kind of oozing out of the rubber dam.
Mm-hmm.
So that has a lot to do with doing a custom template, meaning punch holes, like lay it over the teeth and mark them, and then doing the holes to make sure they're the right size. So the molars will be big, the canines will be a little bigger, centrals will be a certain size. So it's all individual for everybody.
Okay, thank you. And what are your tips for removing old composite and differentiating between enamel and composite? Do you have
I'm going to go back to magnification. So if you can't see it, it's not coming off. The other trick, sometimes I do, if I'm really unsure, I'll take the Explorer and run it across the tooth and the composite. And if it's composite, you'll see the gray line of the Explorer. So that's a cool little tip. Yeah. But again, you need to see what you're doing. So for me, that's under super high mag to make sure that I remove it, but I don't remove too much.
Yeah, and I do. So I do what Adama says, and as I get closer to the interface between composite and tooth, I'll do it dry too with a carbide, and I can really see it. And then you can also do a little black light, which only works if it's like fluorescing. So some composites will, when you use a black light, you'll see it's really bright and fluorescent, and some won't. But that kind of helps too. It's kind of a trick that I use for Invisalign attachments, but I use it for my composites as well.
Okay, I guess then I can ask this question. Someone is asking what a good microscope costs. What would you expect to pay for a decent microscope?
All right, so my old one that with the binoculars that you look through was about 15,000. Yeah. My Siler 3D Vision one that you saw, which is insane, is 36,000. I will tell you, it is the best money I ever spent by far. Hands down, no questions asked. I know it sounds like a lot, and everyone's like, what? $36,000 loops? Trust me. There's no way I could deliver any of the dentistry at the level that I want to deliver it without being able to see things that big. And my ergonomics, I mean, I'm sitting straight up. I have a chair with armrest. I'm so comfortable. I have zero pain anywhere because I'm never looking down. I'm literally looking at a flat screen TV.
Mm-hmm. Pretty incredible.
This is another sandblasting question. how do you ensure the mess from sandblasting is rinsed off adequately? Do you do that before or after placing your rubber dam?
So Adama and I do this differently. So Adama, you tell them how you do it. And I'll tell them
Yeah,
how I do it.
I put my dam on and then sandblast, and then just take alcohol on a gauze and wipe off the rubber dam. And I mean, I'm only doing that because I want to probably take pictures of the cave. So do I really have to clean off that dust? I just rinse off the tooth with air water is fine, but I'll clean up everything around. Our patients always have safety goggles on because I am a messy worker, especially with air abrasion. So
Yeah. So I remove the composite without the dam or anything, and then I air abrade without the dam, rinse them out. And then I get new patient bib, wipe up their face, new gloves, everything, because I mean, it gets everywhere, you know? So then that's when I put on the dam, and my composite's already pre-rolled and covered, everything's protected. So by the time the dam comes on, it's like, I know there's no particles anymore, you know? So it's not right or wrong. We do it differently, but the point is that you need air abrasion. You got to make sure that you rinse it off and clean it off really well.
Thank you. This question, let's see, next question. Could you take a photo with your iPhone 12 nowadays for shade? I know it's not as good as DSLR, but I only need it for shade. Can I do it?
my answer to you is a harsh no.
Yeah.
Unfortunately, iPhone, the lens itself will distort the tooth too much, and the color capture is not the same. There are some products out there.
Smile Line makes one.
Smile Line makes one where you can attach the iPhone to it. That's better. But straight iPhone with your flash, no. If you want to use your iPhone, I think it's like $500 for the gadget from Smile Line. That's 25,000 times better than the straight iPhone.
Yeah, agreed on that.
Do either of you heat your composites prior to placing them?
No, I used to. I don't anymore, just because of some of the science that's out there is about, you know, using the composite again and how you do it. And I think the composites are so good now, and it's just a matter of preference. If do you want it a little creamier? Do you want it a little stiffer? And if you pre-roll your composite and you have it in the right shape, I don't feel like it's necessary to heat your composite. That's just my humble opinion. But if you're gonna heat it, make sure you read the instructions that, you know, how many times can you heat it, to what temperature, because it can change the composition of the composite. So something to think about.
Thanks. And what composite brand do you offer for cosmetics with cost efficiency and beauty simultaneously?
The question was about systems.
What composite brand do you offer for your cosmetic cases? Including a cost efficient, I guess asking about cost as well as factoring in beauty. Maybe that's a simultaneous thing. I don't know if that goes hand in hand or not.
I think what Amanda just said hit the nail on the head, that it comes to all composites out there now. The technology, the beauty of them, they're all good, right? And it's going to come down to how they feel in your hands personally. You know, I know for a fact Amanda and I use one or two composite systems that are the same, but one or two that are not even remotely close. And I can bet you it's not because they don't look beautiful, or I think it's because of the way they handle in our hands. So you need to, you know, I don't mind answering the questions of this and that. You need to just try them. Call your rep and say, hey, I want to try Cosminet's anterior composite, or I want to try Clinician's Choice. Dispense them. I mean, you saw what we do on a glass slab. We dispensed 8 different composites to see what they look like in the same thickness. Play with them. Practice. I mean, I still work on plastic teeth, and I have no shame to say it, you know, but if I'm getting a new product, let's say Cosminet says, hey, would you try my new composite? I'm not going to go do it in the mouth. I'm going to play with it on a plastic tooth and say, hey, I like the way this feels. And so my response to you is going to be based on outside the mouth diagnosis first. And then if I love the way it feels and I like how it shines up, then I'll put it in the mouth and try it from there and start going. So I can't give you a name of one system, because you guys, they all make great composite. You just got to try it and see what feels good in your hands, in my opinion.
Yeah, and it's about understanding the color that you need too, you know, like especially when it comes to the achromatics. I mean, you know, when you look at Cosmetics, achromatics, like they have a clear occlusal and sisal light. If you just listen to those names, would you have any clue what they look like? You don't know what incisal light looks like or what clear occlusal looks like. You've got to roll it out and see it, right? So different brands, those colors are going to be different. I think the Denton shades are relatively the same, and the chromatic enamels are for the most part similar, but where they really change is the achromatics.
Okay, do you have time for a couple more questions?
Sure.
Sure.
Okay, when do you do composite veneers versus porcelain veneers? What's your criteria? Can you give us some rough guidelines when you decide composite versus porcelain?
Adamo,
Man, do you want to take that or you want me to take that?
you can take it.
Or we could, all right, or we could both throw. I mean, the first main one for me is obviously age. I mean, if I get a 16-year-old with peg laterals, you're not convincing me to do porcelain. I don't care what her mother or father want, it's not happening. So I try to, one is definitely age is a big factor for me. Number two, what risk am I putting that tooth at, right? So if I need to close diastemas and the teeth aren't positioned properly and the patient won't do Invisalign and I can't really do minimal prep veneers to get the teeth where I want, I probably could do a little additive composite in between, nothing on the facial or vice versa, and be more conservative and get the same aesthetic result. So I think it comes down to how much damage am I going to do that tooth if it's in porcelain or it's in composite. Risk factors, obviously, the way Amanda and I are both trained, is something we look at very, very closely when we make that decision. It's not fine. I mean, finances play a role, don't get me wrong, but my decision to do a tooth is mainly on risk factor and definitely age for sure.
Yeah. Yeah, I agree with all that. And, you know, in the past few years, I've really branched out and pushed the envelope as to what I do with composite too. I mean, I'm, you know, for young teens, young kids with missing laterals, I'm not doing porcelain Maryland bridges anymore with one wing. I'm doing composite. I'm building it in composite. I'm doing little fiber reinforcement in the back, and it's so easy. It's predictable. It's conservative, and I love it, you know, and I'm saving people some additional costs too. I mean, I'm charging a good amount for it, but I can do it in one visit. There's no outsourcing at all.
Great, thank you so much. Someone is also asking, what handpiece do you use? And also, if you were to get a handpiece to practice at home, do you have a recommendation for that?
I can jump on the and she's probably going to kill me. Whoever wants to know the system, message on Instagram my resident Devin McClintock. I think it's McClintock DDS, and ask her, because she literally built a sim lab in her basement and bought a handpiece. I forget the name off the top of my head. Yes, I make her practice on plastic teeth a lot, so she does it at home. But if you message her, she'll tell you. I don't remember off the top of my head. I think I have NSK. All I can tell you, in my office, it's electric. There's no question, because to do the pericomata that Amanda does, you cannot do that with air. You're never going to get your pedal to go that slow. So it's for sure electric.
I love, and there might be more in the market now, but one of the first to do it was Brasseler. They have these really small electric hand pieces because I have small hands, and they're thinner. The head is smaller. They're awesome. So I use those a lot. But I mean, I have Cabo, I have NSK as well, and I've tried some really cheap off brands too. But you know, you get what you pay for. When you get the cheap brands, they break down. You're not going to repair it. You're just going to buy a new one. So I would invest in a good brand name that will give you some warranties.
Thanks. And another question, what stains composite over time as opposed to porcelain? What do you see staining more? Pardon?
Well, there's a lot of things, you know, it depends on your composite, how you finish it. If it's a microfill, is it a nanofill, or whatever it is. I mean, like Adamo was saying, most of the systems are really good out there. And when you finish it, they all pretty much get a nice high shine. But the difference is in the presence of low pH over the time. With acidic erosion or acid that's coming from the inside out, it's going to change the pH of the mouth. And when that happens, you're going to get some removal of the small particles of the composite. So if you don't have uniform particles like a microfill, or you have a nanohybrid, it's going to take out the little particles first, and then you're left with the bigger molecules. So you're going to see more surface dullness, some staining. And there's a lot to get into that with the science of it. But overall, if somebody has an acidic mouth, they have acid erosion, reflux, or they're soda drinkers or anything like that, it's a red flag for me to say, it's not that I can't give you composite, but I can't guarantee the life expectancy of your composite based on the oral environment.
Yeah.
So.
Okay, thanks. Would you prep the lingual before the lingual shelf when doing a restoration? I'm not sure what that means. Would you prep the lingual before the lingual shelf?
You never need to prep. You just need to make sure there's no sharp edges.
Yeah.
So you can smooth it with a disc, you can use a fine burr, but you just don't want any sharp points like this to build a composite. So just round it off, but there's no real prep that's necessary for the lingual shelf.
Okay, thanks. And then I have a question here. What do you two think of peroxyl rinse nowadays before bonding?
I don't know if I know what they're saying about that.
I'm thinking, are they asking maybe about hydrogen peroxide? Like well, they're calling it peroxyl, so I'm thinking it's hydrogen peroxide, but unless there's some type of cleansing agent called
the COVID protocol, like rinsing before.
Somebody just wrote in the chat, hydrogen peroxide. I mean, I don't.
Peroxyl is a brand name. It's a rinse.
Gotcha.
Yeah, so I guess they're just asking if you do that prior.
We don't. We do a pre-rinse. Honestly, I don't know off the top of my head what it is when the patient sits in the chair now. We were using CTX4, but we just switched to something else, but it's not peroxyl or hydrogen peroxide. So I wouldn't know how to answer that.
Yeah, sorry, I'm not sure either.
Let me see. I do have a few other questions pertaining to the cameras. I know you mentioned, Dr. Notarantonio, that you have 5 cameras at the ready, but someone is asking what 3 cameras do you always have ready to go? And I don't know if they're asking for a label or a type, or are all those cameras different?
Break it down for them between the cropped, real quick, crop sensor and full frame.
I'm going to keep it very simple. Because I could talk about this for 3 consecutive days and we don't have time. For those of you who want to get started in dental photography, if that's what this question really is, I would recommend a crop sensor body. Nikon or Canon, doesn't matter. It's the same. A macro lens, anywhere from 85 millimeter to 105 millimeter, and either a ring or a twin flash. So my go-to everyday camera is a Canon body, because I started with Canon, so I stayed with Canon. I do have a Nikon with a 100 millimeter macro lens and a twin flash that attaches to the end. It's not fancy lights, it's not bouncers, deflectors. I have all that fun stuff. It's for all the artistic stuff I do, but my go-to everyday diagnosis, lab communication, shade communications is simple. Keep it simple. Yeah. Crop sensor body, macro lens, and ring or twin flash. Doesn't matter.
Yeah. And so my workhorse for the past 10 years, I have 5 cameras too, is the Canon 70D, and now there's the 80D, which is awesome. But it's a workhorse. I can do everything with it.
Yeah.
Any pictures that you see on my Instagram portraits or anything, most of them are taken with that.
Thanks. We have a lot of questions, but we have run over quite a bit.
Yes.
You guys have so many tricks in your toolbox. Even I couldn't have imagined how many. For some people did ask if there's a recording of this course. There is, thankfully, because you both have contributed so much to this webinar today, and we want to thank you for spending all this time with us. You're both phenomenal. We look forward to seeing you in person again sooner than later, we hope. And I know that there's just a thread on this ongoing chat of people giving you the greatest shout outs. And so hopefully you'll have a chance to look at all of those. Someone's even asking something about a tattoo. Are there more to come? I don't know. There's so many questions popping up. I can't keep
I just
up
want
with
this
them.
recording because Adamo's dressed up and I'm going to keep it forever because he's never dressed up for me once, ever.
And listen, I don't have any room for more tattoos, folks. So this is it. I mean, the body's,
And I'm
the
certainly
upper
not
body's
getting
covered.
All right. Well, thank you both so much. And thank you everyone
Thank
for
you.
attending. And we'll be in touch. And the
All right.
recording
Thank
and
you,
the quiz is
Erica.
on the way. Thank
Thank you,
you.
guys.
All right.
Bye,
Thanks so
Thank
much.
you.
Have a great weekend. Thanks.